Welcome to Getting Better with Dr. Adam. Dr. Adam Silberstein is a clinical psychologist who has been working in the field since 1993. With a broad range of clinical experience, including state psychiatric hospitals, adolescent residential treatment with a trauma focus, the Department of Corrections, and in the addiction treatment arena. Adam is currently in private practice and serves as a clinical consultant and supervisor for a number of treatment centers.
I just had a great talk with Michel. She's a licensed marriage and family therapist here in West Los Angeles. And she really walked us through, what happens when somebody comes into my office who's just had a boatload of what she called complex trauma, a collection of trauma from an early age that completely shapes an individual's life and results in learning how to deal with that sensitivity to threat assessment by doing all sorts of maladaptive solutions, she referred to them as, such as, finding relief in compulsive behavior and substances, in eating that's dangerous, restrictive behavior or purging behavior or bulimic behavior, and a whole host of other things like cutting or chaotic relationships. And these individuals, these challenging individuals, may have already been to multiple therapists by the time they they meet Elle and walk into her office. And Elle is someone who's trained in a number of modalities and really brings a plethora of knowledge, both in terms of brain chemistry, in terms of resourcing and coping skills in psychology, and just a really good outlook at how to help individuals get better who struggle with a multitude of dangerous issues. She's trained in brain spotting. She's trained in dialectical behavioral therapy, trauma resilience model, and eye movement desensitization, reprocessing. So she just brings a lot to the table, and just what a great look at how to help people who suffer so much. Hi there, everybody. Welcome to Getting Better with Dr. Adam. I'm Adam Silberstein. I'm a clinical psychologist, and really happy here today to have Elle Michel. She's a licensed marriage and family therapist and practices here in West Los Angeles. What's inspiring for me, when I think of someone becoming, doing this work, and I think of, myself, and I think of what did I envision when I was, in college or thinking about going to school or graduating, or as I approached licensure, what was my image of the field? And I thought of, before I got licensed, I remember visiting, I don't even know his name, a psychologist in Encino, and he had this beautiful office. And to me, it was beautiful, and it had windows and it had view of something, probably a street. But to me, it was so wow, it was so big. There was a couch, and he's like, he was telling me how selective he is about his work. And he was winding down his career, and he's really interested in friendly mediation and how, people coming together in a collaborative way to resolve issues. And it's all seemed very peaceful. And I'm like, oh, that's an interesting image of just talking to somebody in a calm, deep, that was a good buzzword, deep depth, good depth work, substantive, and so forth. So what's interesting to me about Elle, and my take, is that I don't know if her clientele experience is so peaceful, right? So I welcome you, right? And what I'm interested in discussing is I don't know if you have this. My sense of you is you have this very, very interesting client base of challenging cases, and a lot of training to boot, and a lot of specialty training. But I just wanted to welcome you, and I'd love to hear about it.
Thanks, Adam. It's great to be here. And yeah, I guess I'll talk a little bit about who I typically work with and my practice, I work with what we call complex trauma. And that involves a lot of borderline personality disorder, attachment issues, childhood abuse, issues around those types of things. And it's exciting.
Can you break that down a little? So complex, just for the
Yeah.
audience, complex is there a not complex?
Yes. So when we talk about trauma, we basically have two categories. We have single incident trauma and complex trauma. So single incident trauma would be like somebody whose life is fairly secure and stable and predictable. And then let's say they have one incident that's very scary or very damaging, like they get in a really bad car accident or a plane crash or something very severe like that. So they may develop symptoms of post traumatic stress disorder related to that one incident, but the baseline that they have established in their life is pretty um, calm and stable. When we think about complex trauma, we're looking at people who maybe have a lot of different traumatic events accumulating over many years, typically starting in early childhood, typically related to family systems. So, this is where we may have somebody who has a parent or a caregiver who's mentally ill or addicted to drugs or alcohol, or who a person who's suffered some type of child abuse that was ongoing for a number of years. And so these types of folks typically can develop a lot of different issues related to their early childhood experiences. It can turn into an eating disorder, it can turn into a substance abuse issue, it can turn into a personality disorder. Basically, we're looking at the origin of all of these different symptom presentations as being some form of repetitive trauma, typically beginning earlier in life.
So it's for individuals who collect trauma.
Yeah.
Life unfortunately for them is about collecting ongoing
Yeah.
trauma.
And one thing we know about trauma that's fascinating, but also, awful, is that once somebody's been through a traumatic experience, they're more vulnerable for any experience they go through after that to be re traumatizing. Um, because their nervous system is so frazzled from the original trauma that they lose resiliency. So, a child who maybe has, maybe is bullied at school, that may not be traumatic for a child who comes from a secure home environment. But for a child who's being abused at home and then they go to school and they get bullied at school, that's going to impact them a lot worse.
Mhm. So that the wiring, and
Yeah.
when you speak about resiliency, the resiliency would be even though I get hit, so to speak, or I take or life gives me a very tough knock,
Right.
right? I have the ability to cope
Yeah.
in a successful way that helps me walk through something.
Right.
But if I keep collecting traumas and legitimately, I
Yeah.
go home, I'm traumatized. I go to school, I'm traumatized, right?
Yeah.
Then you're saying it shapes my whole processor, right?
Yeah.
My brain, right,
Yeah.
is actually starting to be shaped, and I start to see the world in a
Totally.
traumatic light.
Totally. Yeah. So typically when I'm working with these types of folks who've been through a significant amount of traumatic events, we're not going to just do like 3 to 5 sessions of EMDR and their symptoms are going to resolve.
Mhm.
It's going to be a longer process. It's going to involve developing and building resiliency, doing a lot of resourcing. Resourcing is like trauma language for building up internal models of safety and security in the brain and in the nervous system. So, thinking about a place where you feel safe and imagine yourself being in that place. For someone who's never felt safe in their entire life, we're literally forging new neural pathways with that simple exercise. So, the work is going to be take a little longer and be a little more involved.
Right, so it's not like the man I saw who was a psychologist who was just having like friendly mediation where everybody comes to the table and we all agree it's, we're going to do this for the best interest of the children, and how do we agree and how do we disagree kindly, right? This is not what we're talking about. And when to make it come alive, right? Bullying at school is terrible, right? It's like I have no voice and I'm being stepped on and I'm actually, being physically or physically dominated by my peers
Right.
potentially, or I'm being exposed and shamed in a public way on social media, and it's very hard, right? I'm marginalized, I'm ostracized, and I'm that kid who doesn't have a voice and can't and doesn't have the ability to stand up without being shut down. That's hard, right? But I want to bring it, bring to life the experience of coming home to a household, right, where there's potentially what you're referring to as trauma, right? So and I kind of feel that word, and I've spoken about it with other guests here. That word it's losing something because I feel like it's just a household word
Yeah.
now. So when we say and when you say the header complex, right? And a complex trauma, it's not just a one and done trauma,
Right.
it's a ongoing thing.
Right.
So can you bring to life the scene in early childhood that comes to mind for you, just generically,
Mhm.
of what does it mean to have to be the experiencer of early childhood
Yeah.
complex trauma?
Yeah. I mean, I've worked with a lot of people who had parents who were emotionally or physically absent for a variety of different reasons. Sometimes there's socioeconomic reasons, there's poverty, there's incarceration, there's economic instability in the family. But what people describe it as being like is like there's no safe place. There's no security. They don't know when they walk in the door, is their mom going to be drunk or high or happy or sad, or if they're going to get abused or not abused on any given day at any given moment. So it creates this tremendous amount of fear and like this tremendous need to protect themselves constantly. And that can really warp somebody's sense of self and their coping strategy to carrying that with them throughout their entire experience, right? Because what we know about attachment theory and the idea that um, the relationship an individual has with their early caregivers, that forms their worldview, right? So if their caregivers are meeting their needs, then you're going to get a healthy, confident person who says, I have needs that are worth being met. And I'm going to go out in the world and expect that other people can also meet my needs. Whereas if you have a person whose caregivers are either incapable or unwilling to meet even their most basic needs, they start to develop a story like, my needs are not worthy of being met. My needs are wrong. Therefore, I'm wrong. Therefore, I can't rely on other people. I can't trust other people. And these patterns accumulate in their relationships over the years.
So it's warping a sense of safety
Yeah.
from the gate.
Yeah.
And I don't know if you're aware, the Surgeon General of California, right?
Yeah, I heard about
Did you
that.
hear? And do you have? There's adverse childhood
Yeah.
experiences, are something that is getting Kaiser certainly got their attention.
Yeah.
And I mean, are you familiar with it?
Yeah, so the ACEs study is fascinating study that was following children over the course of their lifetimes and looking at a series of adverse childhood experiences. I think they had 10 categories, like if you had poverty, abuse, a caregiver who was mentally ill or alcoholic, things like that. And there's kind of a checklist. You can actually take the little quiz and score yourself where you rate on the ACEs scale. And the higher your rating, the more negative health outcomes are associated with that. So heart disease, diabetes, cancer, things like that.
Not not even talking about mental health, and
No, physical health.
in addition to mental health
Yeah.
issues, which are obvious, right? That there's definitely and the wisdom of this to me is it's also economics, meaning
Yeah.
early identification. Early
Yeah.
identification will actually improve healthcare outcomes,
Totally.
right? Not just
Totally.
mental health, but physical health as well.
Yeah.
So to me, the discussion of bringing to light So we don't, we don't water down the word trauma, right? Is that these early adverse experiences, right? Potentially that any one of them, any one of these stressors,
Mhm.
financial, right? Alcoholic parent, right? Mental illness in the family,
Yeah.
right? Something like that. And as the child, start to interpret the world as a place
Yeah.
that is highly unsafe, and that I long for my needs being met, but I start to lose I don't have the resource to even contemplate that
Right.
because I'm too busy in survival mode.
Right. Exactly.
So that's the experience, and I really encourage people to watch some sort of film and really, really bring this information. There are many movies which could capture like household trauma that I think that could really highlight this for us. So if I start collecting these things, right, I start to develop, um, I would say, patterns in relationships where I don't feel safe.
Mhm.
And I start to develop symptoms. So
Mhm.
you're talking about my eating can get funky,
Yeah.
right? And that's not just like I have a few extra, M&Ms.
Yeah. Yeah.
Right? We're
Right.
talking about, you said eating disorders. We're talking about pronounced,
Yeah.
pronounced maladaptive relationship with food that can include things like purging
Yeah.
excessively,
Yeah.
exercising excessively, using laxatives,
Right.
restricting your food to the tune that you get so thin and have a distorted sense of your body that you could die,
Yeah.
right, in
Yeah.
anorexia. So that in addition to collecting trauma, you're collecting other symptoms.
Right. And the thing that I like to keep in mind is the idea that as humans, um we're genetically social, right? We're a social species. And for most of our time on the planet Earth, our survival has depended upon us being interconnected with each other in communities. And so when you have early childhood trauma, and you learn that it's not safe to connect with other people, you're losing something that's actually very, very important to human survival. And so you're losing your ability to emotionally regulate by connecting with other people. So everybody on the planet has to regulate their emotions. It's not optional. So if you can't regulate your emotions by, let's say, talking to your mom or dad or talking to your friend or your sibling or whatever, then you're going to come up with some pretty creative ways of regulating your emotions, typically through compulsive or addictive behaviors. So that's when we might see the substance abuse starting, the disordered eating, or both. I mean, I work with a lot of people who have an eating disorder and a substance abuse issue, you know, and they have depression and anxiety and they have trauma. And we're kind of playing whack a mole with the symptoms, and they're kind of cycling between different emotion regulation strategies with the aim, once they're in therapy, of learning how to emotionally regulate themselves in a safe and healthy way.
You know, you've got me thinking. I really feel like as a culture, we take a lot of things for granted,
Mhm.
just sort of basics. There's an entitled assumption that things are going to be in a flow,
Mhm.
right? We count on a lot of things as predictable, right? Like if I get to the airport, there'll be a person at the counter that could accommodate me, right?
Right,
That there'll
right.
be parking if I need a parking spot, that I can do certain things, pay for it. If it's crowded, I can pay for it, and I can have an experience and count on it. And it's kind of like it's the fires now. It's the end of October. In West Los Angeles here, there's fires going on, and it's mayhem.
Yeah.
It's mayhem. Nobody knows the predictable life as we know it is not here in the same way. And
Right.
once that's and I think for me it's important to connect to what would happen if what I thought is business as usual, just predictable, right? If I had experiences that made all of those social encounters completely threatening and unsafe because I don't trust anybody or anything to just be business as usual.
Mhm.
And I bring to that experience, whether it's talking to a new person I meet or talking to someone I'm working with or talking to someone I'm living with, I bring with it a sense of it's not business as usual, it's completely threatening.
Yeah.
And you're talking about emotional regulation, meaning Meaning for those listening, like I'm not chill.
Yeah.
I mean, I'm so not chill.
And how do I get chill? Like, how do I go
Right.
from being excited to being calm?
I don't know how to
Or
do that. I don't know
yeah,
how to get chill
right,
because nobody ever demonstrated to me, and we can take this for granted and be entitled and say, well, just get chill. Well,
right,
where did you learn how to get chill?
right.
You think is it for the person who doesn't have adverse childhood experiences? Do you ever appreciate that you actually learned
Right,
somewhere to get chill?
right,
And if you didn't know, you're going to turn to.
right.
Right.
And it's, more and more we're looking at trauma as not just a mental health issue, but an issue of physiology, right? Because we're looking at the nervous system, we're looking at the sympathetic and parasympathetic nervous system and how the sympathetic nervous system is basically what turns us up in terms of getting excited, getting agitated, fending off threat, and the parasympathetic turns us down in terms of relaxing and getting calm. And so, for someone who's been traumatized, there's this pretty significant imbalance there. And we also have research that shows us when somebody is traumatized in their early childhood, and this can start in utero, for example, if you have a mother who's suffering domestic violence or whatever, and then it's going to affect the fetus, right? But the part of the brain that's responsible for creating big emotions, the limbic brain, actually gets bigger. And the part of the brain that's responsible for calming down emotions is smaller.
Because the part of the brain that's doing threat assessment and coping with threat is just much busier.
It's just a lot
It's on
busier.
overload.
Yeah. So we can do brain scans of people and look at the different structure of the brain actually being different sizes and correlate that with these adverse childhood experiences. So this is getting into what we would call like the invisible illnesses, right? Where on the outside, somebody just looks like every other person, but on the inside, they're operating with a very different brain structure that is inhibiting their ability to calm themselves down when they're
Right.
feeling threatened.
So for lay people, it's the anti-chill brain
Yeah.
structures. Right? This is the
Exactly.
anti-chill. This is, hey,
Exactly.
just chill, right? If we do an MRI of your brain, right? If we do functional MRIs, you have, for the just chillers, you have better resource to just chill. You're
Yes.
better structures to
Yes.
just chill than the people who've had these adverse
Yes.
childhood
And
experiences.
those structures start developing in the womb and kind of go from there. So,
So I want to bring it. So you spoke about this nervous system that has, the sympathetic piece, which is the exerciser of threat assessment, and then the parasympathetic, which is the coming down and learning how to relax.
right.
So, and you also mentioned that there's when I'm in overdrive and I don't know how to chill, right? These other compulsive behaviors, right? Do they serve as parasympathetic replacements?
Yes. Yeah.
So, but they're not activating the parasympathetic nervous
They
system.
are. They are activating the parasympathetic nervous system.
So when I cut, or when I
Yeah.
restrict, or when I overeat, or when I use drugs, it's a parasympathetic. So what is what is the benefit to the
That it,
individual of using those?
yeah.
Yes, it calms them down, but what does it actually do from a physiological
So,
standpoint?
from a physiological standpoint, it'll reduce heart rate, it'll reduce breathing rate, it'll flood the brain with serotonin and dopamine, and it'll create a feeling of being calm. And I try to reframe it with my clients as to looking at these alternative coping mechanisms as actually being super adaptive, right? Because so many people come in with so much shame, and it's really about how did you survive? For the person who's self harming, this behavior was a survival mechanism. Now, if they get to the point where they're in therapy, most likely this behavior has caused them a pretty significant amount of problems in their life. So we want to let go of the behavior, but we don't want to frame it as, oh my God, that's so horrible and awful that you did that. How could you do that? We want to frame it as, wow, you've really been through a lot and you've figured out some pretty ingenious ways to soothe yourself, and they're not working very well. So are you willing to trade them in for some other ways that are going to work better?
So I like the idea that there's a respect on your part, right? I honor you because you found solutions.
Yes.
Well, given you did the best you can with what you have
Yes.
as a person on this planet, as a human, you had to learn how to we all have to learn how to self-soothe
Right.
because we can't be in sympathetic nervous system, to
No.
use your language. We can't be in chronic threat assessment.
Right.
How do we calm down? How
Right.
do we regulate? And you learned, right? This is what you devised. Nobody
Right.
taught you, but you devised a system that could actually help you soothe.
Right.
However, and I honor that and I respect that, right?
Right.
And in some ways, even dare I say, celebrate it. Celebrate your experience of survival.
Right.
And yet, right? But if we're taking an honest look now, it's not working anymore,
Yeah. Yeah.
right? So what doesn't work about those things?
Well, they
Because you said
kill.
whack-a-mole earlier. It's like if I'm not cutting, I'm restricting. If I'm not restricting, I'm using
Yeah.
drugs. So what's not working?
I mean, the truth is that people die. People die from these coping mechanisms that they're using to try to survive. And that's really the um the most challenging thing.
Uh-huh.
And people die from eating disorders, people die from substance abuse issues, and if they don't die, they have some pretty serious problems in their quality of life.
So I want to go back to the psychologist in Encino,
Yeah.
right? Walking into his office, this nice couple who's amicably separating, right? How do we take care of our kids? Let's come up with a plan. I walk into Michelle's office and I got somebody with active wounds because they've cut,
Yeah.
right? Looking like death's doorstep could potentially in their eating disorder,
Right.
right? Or high as a kite and just had a DUI. So just to take it back to the original part of this discussion, when you were up and coming and in training, did you think this is what a day in the life of did you picture yourself more like the Encino guy, or
No,
did you picture this?
I definitely pictured this. I mean, um I've worked with a lot of different types of clients with a lot of different types of issues, and probably because of some of my own adverse childhood experiences, I find working with people who are very, very stable and chill, I find that a little boring. Like I am energized by working with people who are really in the throes of some pretty serious issues. It's kind of like never a dull moment. Um, but I really, really enjoy it, and I have kind of the stamina and the bandwidth to be able to do that, which a lot of people don't have.
So in Day in the Life of El Michel, it's potential, right, that you can see this 6, 7, 8
Yeah.
times a day,
Yeah.
some version
Yeah.
of, and it's not a, to use the word chill, it's not calm, right?
Yeah.
It's not calm, it's intense.
Well, and I'll just also say that, not all of my clients are at equal levels of severity, and they're not all always in crisis, right? So I might have one or two clients out of a caseload of, let's say, 20 who maybe are experiencing some type of crisis, right?
At any given
At
time.
any given time. Yeah. But it's not like every single client who walks in my door is like actively suicidal.
And that could rotate,
Yeah.
meaning that could rotate. If two get it this week, another two will get it next week,
Exactly.
and so forth. So is part of your, in terms of the way, the outlook for those listening, the specialties, the various specialties from from EMDR to trauma resilience to DBT, right, to
Yeah.
brain spotting,
Yeah.
is it the different specialties that you bring, is it mostly, if you really conceptualize it, about parasympathetic activation, how to self-soothe in healthy ways and
Totally.
regulate,
Totally.
and everything could be seen in that light,
Totally. Absolutely. Yeah.
right?
And how to build safe, healthy relationships, how to let go of maladaptive coping patterns, and how to I do work with clients, for example, who maybe they've already done a lot of work. They're not self-harming, they're not actively in an eating disorder, but they're still getting triggered by things that happen in life that remind them of severely traumatic experiences. So they're no longer coping maladaptively, but they're still suffering. They're still in a lot of pain. So that's when we bring in the EMDR, the brain spotting, to really unpair that paired stimulus and response. So the
So let me
person,
back up for
yeah,
a second. You you're a licensed marriage and family therapist, but you've done a boatload of specialty training. And it's not like a 3-hour course. We're
Yeah.
talking about hours and hours and hours and hours of training in each dimension,
Yeah.
from EMDR, eye movement desensitization reprocessing,
Yeah.
DBT, dialectical behavioral therapy, trauma resilience therapy model of
Yeah.
treatment, as well as brain spotting, right, which is another trauma therapy,
Mhm.
right? So
Mhm.
there's so much involved. So in walks this person who's got a boatload of issues, and they may, and I would assume many of them have been through the ringer with multiple therapists. So
Yeah.
you're not this is not the first rodeo.
Yeah, typically.
Right? No, so you could be therapist number 10,
Yeah.
right? So what do you how do you take a step back, and where do you even start? How do you
Yeah.
take a step back and say, okay, what am I going to do to start building emotional regulation
Yeah.
or coping?
The absolute most important first thing is building a connection with that person and establishing that this is a safe environment, that I'm a safe person, and that there no harm is going to come to them through me or through being in my office. And so that rapport building can look like talking about what movies they like, or what they like to eat, or where they like to spend their time, but just establishing that sense of safety, because folks who've been through these type of events tend to be, like, on high alert for, first of all, their bullshit meter is very, very high, right? So I have to be really authentic, really real.
You can't fake it.
I can't fake it. No, I
You have to
can't.
mean it,
I
or
can't
they'll
fake
eat
it at
you up.
all.
Right.
Yeah, and just kind of talking, establishing that sense of trust and safety, and then of course the first thing we're going to work on is if anything is going on that's actually threatening to their safety, right? So I love how DBT presents um, a target list in terms of severity. So level 1 target behaviors would be anything like suicidality, self-harm, anything that's imminently dangerous. And if any of those behaviors are going on,
All bets are off.
yeah, we're not going to spend the session talking about how you might break up with your boyfriend. We're going to spend the session talking about, are you physically safe? How do we get you physically safe? Because that takes priority.
What would be a level 2?
A level 2 would be something like a therapy interfering behavior, like being chronically late to therapy, missing sessions, something like um, interpersonal stress in relationships that maybe are like the person is reacting to them, like by maybe using substances or maybe doing some maladaptive eating behaviors, but it's not imminently dangerous, right? Maybe
But
they're
it's
drinking a
dangerous
little
enough.
too much.
Right, if heroin is my solution,
Right.
it's a worthy topic, right?
Right.
It's not hospital right away, but it's a worthy topic.
Right, like IV heroin use would be a level 1. Someone who's partying a little too hard and maybe drinking a little too much on the weekends would be a level 2, like that kind of thing.
So you're assessing the first off, what's the immediate piece of business that needs to be
Right.
addressed if it's there,
Right.
and if it's not there, because 18 of the people in a given week won't have an imminent crisis.
Right. Right.
So then, what does it look like? What does it look like? So you're picking you're like, you have to pick which one. You have so many
Yes.
places to go.
Yeah.
So how do you suss out where you're going to start?
Well, typically we're looking at safety, and then we're also looking at what the client is presenting with and what they're distressed about. If the client is coming in and they're really, really upset about one thing, I'm not going to just completely ignore that and say, no, 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 we have to talk about X, Y, or Z, right? That can get a little bit tricky because I have worked with clients who part of their process of being kind of clinging to these maladaptive coping mechanisms is that they're creating crises in other areas of their lives so that they don't have to talk about the eating disorder or the substance abuse or the self-harm or whatever. So I'm kind of operating as a detective a little bit, like, hey, okay, let's talk about this, but let's bring it back to that and what's going on with, self-harm or whatever it is.
So when do you start employing all these specialty techniques?
Typically, first, with every client, we're going to do a lot of assessment. we're going to assess for safety, and I'm going to be assessing for their ability to emotionally regulate in a safe way. I've had quite a few people come to me because they've heard about EMDR and they want to do trauma work and they have all this trauma history and they're really excited about it. But when we get into assessment, I may find out that they're actively suicidal, and that is a no-go. We are not going to do EMDR with someone who's not physically safe, right? So typically I'll bring in some of the DBT stuff, some of the tip skills. Tip skills for DBT is like crisis survival skills.
Like, give me an example of one.
Like basically when somebody's really, 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 maybe they're having a flashback or they're really agitated or manic, like using using an ice pack to kind of help them ground, or using deep breathing techniques to kind of help them get back in their body in a safe way.
Giving them resource to come
Yeah.
back. And then let's say they're like, hey, this is really helpful. I get you. You're right. I can't be suicidal. And then diving into a trauma, I have to
Yeah.
be safe. I do it. So
we help them stabilize. We see how that goes for a little while and how they tolerate stressors.
Could be weeks or months.
It could be weeks or months. Yeah.
Right.
I mean, for some people, it could even be longer. But we see when they feel like they're ready to dive into some of that trauma stuff. And then we bring on, with trauma work, we start with building up a lot more resources, installing the safe place, doing a lot of building up their internal sense of safety even before we do that with the bilateral stimulation with EMDR or brain spotting, even before we jump into the actual trauma processing.
So that parasympathetic technique,
Yes.
right, that they weren't taught these things,
Yes.
right? You're going to start teaching safety,
Yeah.
right, and regulation
Yeah.
early on,
Yeah.
right? Early on, so that they have at least some awareness and sense of what does it mean to experience safety,
Mhm.
right?
Mhm.
I can actually generate it myself if I employ these techniques.
Exactly.
And then you introduce the trauma,
Yeah.
right?
The trauma process.
The trauma process. And you use words like bilateral stimulation.
Yeah.
You use the words like pairing, right? What is that? What are you saying for those who don't know?
So I know I'm throwing out a million different words.
No, you're
so I
good.
should explain myself. EMDR and brain spotting both use what we call bilateral stimulation. And bilateral stimulation is stimulating each side of the body, left and right, back and forth. It's very simple. With brain spotting, we have the client actually put on headphones, and there's music in the headphones that goes from left to right in the ears, back and forth. And so that creates the bilateral stimulation. And for those of you listening, I'm tapping on each of my ears, left and right, back and forth, to kind of model the stimulation. So the idea is that when we bring in the bilateral stimulation and we have the person talk in specific formulated ways about the traumatic experiences they've been through, the way that the brain is storing and holding on to memories actually changes, and those memories are released from the nervous system, from the brain.
So cultivating a different experience of discussion and memory
Yeah.
of the event,
Yeah.
right? With an association, right?
Yeah.
Of safety attached to it.
Yeah.
Right? Will actually, and this is really important. It's a very simple, it's a very
Yeah.
simple idea,
Yeah.
right? If I engage this tapping mechanism, left to right in the
Yeah.
brain, and I have a pairing, right?
Yeah.
Pavlov's dog, right?
Yeah.
If I have a pairing of an experience that's safe, right? I may digest that experience differently.
Exactly.
And it's not fancy, it's not necessarily deep, it's not interpretive like a it's just
very
a go have
simple.
your experience.
It's
just
very
in a different way.
simple. Yeah, basically what we're looking at is the adaptive information processing model, which says that, like, if I cut my hand, my body is going to start to heal that wound immediately. That's just my body's natural state. If something gets in that wound and interrupts the healing, it's not going to heal. It's going to get infected and fester. The same thing goes for our brains and our nervous systems and trauma. So if I'm wounded by a traumatic event, my brain is going to try to process through that event, process through the memory of that event, and heal. Typically, if I actually exhibit symptoms of post-traumatic stress disorder, that tells us that that healing process has been blocked. So when we bring in bilateral stimulation, we're removing that block, and the brain is healing itself, and the memory goes from being very activating to where somebody can remember a traumatic event and their heart rate increases and they feel tense, to being not activating.
So
So
the belief, the provider, which is you, right,
Mhm.
doesn't have a belief that I'm going to give you some new information about your experience at that moment per se in that experience. It's more about, if I offer this coping technique, you organically will
Exactly.
have an experience of reprocessing it
Yes.
in a safe way.
Right, exactly. So if we think about, if you remember some event from your past, typically you can think about it and you're not physiologically re-experiencing it. With trauma, the person is physiologically re-experiencing the threat. So what we're doing is we're just removing that threat from the brain and from the nervous system.
So it's not in more old school uh, therapies. It's not an interpretive. You're not
No,
looking at symbolism.
no.
You're looking at a natural, just a natural. You're an agent to helping a natural
Yes,
healing process.
exactly. We're just removing the block. And this is one of the reasons why two people can go through the same experience and one person can develop post traumatic stress symptoms and the other person doesn't, right? That has to do with the person who doesn't develop post traumatic stress symptoms, their brain releases their memory of the experience and processes through it naturally. And maybe it wasn't a fun thing or it was a slightly disturbing thing, but they're not activated around it. The person who's developing those PTSD symptoms, it's because there was some block in the healing process. So we're just going in, we're removing that block, and we're allowing the nervous system to do what it does best
Right.
and
So for
heal.
those who've been through war zones, those who've been
Yeah.
through terrible events, you may have a subset, a large subset of people who don't have post. Not we're not saying they're not impacted,
Yes.
but it's not as charged and
Yeah.
activating,
Yeah.
and it's not a judgment. Some people are more vulnerable
Yeah.
to the disruptor of the healing process and
Right.
trauma, and also may have atmospheres that don't support healing.
Exactly.
So I'm curious, just for those listening, right? What would be an example of the type of case, right? Obviously, um, to the best of your ability to explain, what would be an experience that you had in this work with all these sort of maladaptive types of coping mechanisms
Mhm.
that, looking back from point A to point B, you're just blown away that this individual, is like, just blew you away.
Yeah.
What has blown you away?
Um, I had a client who, and obviously I'm gonna mix things up a little bit for anonymity,
Of
but I've
course.
I've worked with clients who have dealt with pretty severe childhood trauma around verbal and emotional abuse, a parent being mentally ill and addicted to substances, and then that person has gone on to develop an eating disorder and a substance abuse addiction. And through therapy and we've through ongoing therapy.
So before you even go there,
Yeah.
functionally, that person walking into your office, could they hold down a job?
No.
So let's just, like, I want people to appreciate this. So could they hold down a job?
No.
No chance, right?
No chance.
No chance. How long do they last at a job if you put them in a
I
work
mean,
environment?
a few days.
Max, right?
Yeah.
So we're saying somebody who's gonna get fired or not show up,
Yeah.
right? Could they be in a relationship,
No.
right? So no chance of a significant other,
Yeah.
right?
Yeah.
No chance.
No chance.
How long does that last? Or they can't even get a significant
They
other.
can't. I mean, they're maybe engaging in romantic or sexual relationships in ways that are really damaging to them.
But
Like,
not a committed other.
but not a committed other. They're maybe engaging with people who are victimizing them.
Right.
Actually.
And what's it like to live in their own skin?
Oh my gosh, it's awful. It's horrible, painful, miserable.
Erratic.
Yeah.
Super
Chaotic,
highs, super lows.
unpredictable.
Unpredictable. So just walking a day in the life of this individual, it's like, you can't hire them.
No.
You can't marry them, right? It's hard to be friends with them, right?
Mhm.
It's hard to parent them,
Yeah.
right? So this is me trying to bring to life, like, again, the difference between the Encino psychologist, who actually was so helpful to me. I don't want to put him down. He was such a great intro to professional life,
Yeah.
and a day in the life of Elle Michel, potentially somebody who is just not
Yeah.
doing well on any front in
Yeah.
life, right? And then fast forward, right? Safety issues addressed, safe relationship with you, coping mechanisms, reprocessing.
Yeah.
So what blows you away?
I mean, it blows me away that I've seen people go from that state to being healthy, functional adults who are holding down jobs for months and years and building supportive friendships and engaging in healthy romantic relationships, building self-esteem, building really their ability to function in the world
And in a shocking way.
in a
So
shockingly
they would be
amazing way.
labeled by the universe who knew them prior to meeting you. They would be labeled things like batshit crazy,
Yeah.
or totally zero confidence
Yeah.
in any ability to ever have anything remotely work for them.
Yeah.
Right? And out of this process walks over time, and when we
Yeah.
say time, it could be years,
Yeah.
right?
Yeah.
A functional person
Yeah.
who is participating in the world.
Totally. And I also just want to put out there that because I work with people of such high severities, I frequently am referring to higher levels of care, meaning if somebody is, you know, engaging in life-threatening behaviors, it may not be appropriate for me to be seeing them in therapy once a week or even twice a week, right? So I'm not just seeing people who are all constantly suicidal and I'm like, "Oh, it's fine, just come back next week," right? I'm very in every session assessing safety, assessing risk, and monitoring, do we need to refer you to treatment? Do we need to refer you to residential? That kind of thing.
What if they refuse?
If they refuse, it can get really complicated. I mean, I have discharged people from my practice because I felt that the threat was so high, the imminent danger to their lives were so high that I couldn't ethically continue seeing them because I felt that would be enabling them in some way, enabling that refusal. And then there's other cases where they refuse, but they're willing in other ways to try other coping mechanisms or to try other areas of support, and so I've kept them.
So interesting. You referenced earlier, got me, therapy disruptors.
Yeah.
So therapy disruptors may not be imminent in this moment, but a therapy disruptor could be, I'm actually not participating in anything we're doing here,
Yeah.
right? Versus I have a recommendation. I'm not willing to do that one, but I'm not willing to do A, but I'm willing to do B, C, and D
Exactly.
is not necessarily a therapy disruptor.
Not
But
necessarily.
I'm not willing to do A, but I'm not willing to do B, C, or D, but I do want to see you is a therapy
That
disruptor.
yeah.
So why are you here?
Yeah.
Right?
That can get really complicated, and this is an issue that every clinician gets to kind of figure out what they're comfortable with. There are some people who will continue working with people if they refuse a higher level of care, and I've done that in certain cases, but I also have said to somebody, I can't keep working with you. It's not safe to do that.
So if you wanted to just in for a person in the field, or for a person who's just as interested, and I really tried to bring to life, how this isn't the amicable separation case, right? What are some good resources or materials for people
Yeah.
to look at to help gain knowledge and
Yeah.
awareness of what you work with?
I would highly recommend the book The Body Keeps the Score by Bessel van der Kolk. That is going to give you a really, really good picture of trauma and how trauma affects people. Um, I'm forgetting the name of the book, but it's a book by Jody Herman. I think it's called like Trauma. It's called Trauma something. But it's another really great book. And anything, by Marsha Linehan, she's the person who created dialectical behavior therapy, is phenomenal.
So brings to life individuals with complex trauma
Yeah.
and the other types of symptoms that they
Yeah.
have.
Yeah.
Very and actually I am going to take another minute. One more thing.
Yes.
Can you just give a sense of specialty training, right?
Yeah.
How much time and energy did you put into this?
I put in a lot. I put in a lot. I mean, I did attachment focused EMDR, which is 3 3-day weekends. and then 10 hours of supervision, and then I'm receiving ongoing consultation for that. Brain spotting, I've done 2 3-day weekends, and I have another one coming up in November. Trauma resiliency model was 1 3-day weekend that I did.
And then DBT?
And then DBT was, I mean, I got a lot of training working at Clearview, which is a DBT treatment center, and then I did a week-long training.
So
40
this is
hours.
all for those listening. This is after getting a
This is
degree.
after grad
This
school.
is after all a part of just your own experience and
Yeah.
training that you've chosen. So it's very
Yeah.
cool. For those who are listening, how would we reach you if we want to
Yeah.
get to learn about your services or access you for help?
Yeah, you can call me, you can text me, you can email me. I'm sure you guys will include.
Why don't you share that?
Oh, yeah. So my number is 310-383-5148. And my email is lmichelpsychotherapy@gmail.com.
Should we spell that?
Yeah. Yeah. That's ELLEMICHELPSYCHOTHERAPY@gmail.com.
That's amazing. Well, thank you so much.
Thank
It was such
you.
an informed, good conversation. I appreciate it.
Thanks, Adam.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.